So, good morning, everybody. My name is Daniel. I'm from Kantar Health UK, and I'm the oncology lead. And we're very excited today to be able to work with Dr. Arkenau from the Sarah Cannon Research Institute to talk to us today about how immunotherapies are changing the oncology landscape. This is undoubtedly one of the most exciting areas in oncology at the moment, and for those of you who were at ASCO or have seen all the news that's come out of that, you'll be familiar with the hype and interest around this area. Dr. Arkenau is going to take us through what some of the latest developments have been in this area and what they may mean for clinical practice in the future. Throughout the lecture, if you have any questions, please do not hesitate to come off of mute and ask them, but we also have a Q&A session at the end of the presentation for those of you who prefer to wait until the end. So without further ado, I'm going to hand over to Dr. Arkenau, who's going to take us through this very exciting lecture.
Yeah, good morning to everyone joining this meeting, this WebEx. Just to introduce myself, I'm a medical oncologist and the Executive Medical Director for Sarah Cannon Research Institute here based in London. We're part of a larger drug development network based in Nashville, Tennessee, with several sites doing drug development every day. And for us, the last few years were particularly focused around the development of new immunotherapies. And here in London, we have been heavily involved in many of these new drugs. And today, I really want to share with you the exciting news, the very early news on the impact of immunotherapy. And just as a little, to set the scene, actually, cancer immunotherapy has been voted by the Science magazine in 2013 as the kind of drug class of the year. And just recent highlights and headlines over the last few months, whether in US-based or UK-based newspapers or magazines, immunotherapies were all over the place, even asking have we cured cancer and the cancer treatment and healing powers of immunotherapy, just to name a few things. So big mainstream media taking on these exciting news. Just want to start and really set you back to basics, and I think that's really important to understand how immunotherapy works and where we have an opportunity as drug developers and oncologists to develop drugs. We very basically separate two ways of immune response. One is the innate response, and one is an adaptive and specific immune response. The innate response is really recognizing cancer or any proteins and pathogens very unspecifically via macrophages, monocytes, eosinophils, or natural killer cells, where specific adaptive response means that proteins or cancer proteins in this case, in the case of immuno-oncology, are recognized by T cells. T cells specifically target these proteins, and the B cell function is a memory function. So if a protein is getting expressed again or invades the body, B cells and system will work. So this is what we call the adaptive design. And just moving on here, there are several ways where we can target these pathways. Starting at point one, it's usually the cancer antigen, the protein which is released, and whether by chemotherapy or by cancer itself, it gets then recognized by dendritic cells, often in the lymph gland. The dendritic cells helping to prepare so that T cells can actually understand what protein antigen they have to recognize. The T cells then, once being primed in the lymph glands, get released into the blood stream, and then have the opportunity to fight cancer protein, in the tissue. And there are several steps involved in this cycle. And as you can see in those forms, there are several ways in this kind of cascade where we can target the cancer cells using immune mechanisms. And just today, I really want to focus on the T cell as a target for immunotherapy, and only want to focus on actually two main targets, the checkpoint inhibitors, CTLA-4 and PD-1/PD-L1 inhibitors, where we've seen most of the data at ASCO this year at our annual cancer conference. There are obviously, as you can see here, several other targets, which on the right hand you can see receptors which inhibit T cell response. Those can be targets, but also there are lots of drugs in very early development or preclinical development which actually activate T cell function, and they're what we call activating receptors. So it's very basic here, but as you can see already, lots of opportunities to target the immune system. And just to setting the scene in terms of landscape, what's going on here right now, checkpoint regulators, as I mentioned, are the ones I will talk about, the PD-1, PD-L1, and CTLA-4 inhibitors. There are lots of news on cancer vaccines. Then we have heard at ASCO this year the first time of combinatorial therapies of immunotherapies plus chemotherapy plus targeted agents, or in combination with other immunotherapies. I want to highlight some of these findings here as well. And then the immune modulators, there hasn't been much presented this year, so I will leave this out. Again, for the biotech and pharmaceutical industry, certainly this is a growing market. 2012, $1 billion in terms of revenues. This will increase over a 10-year period up to $9 billion. And, these numbers are purely the immune modulators, the ones where we target T cells, vaccines, or other functions of the adaptive immune system. I haven't included here other immune therapies. Often people refer to as antibody drug conjugates or other specific antibodies to certain receptors. I haven't included these numbers, but this is really the kind of market forecast with an annual growth of around 24% over the next 10 years. And you can see it down in this picture as well, that the major, pharmaceutical industry companies have heavily involved in these clinical trials. Around 700 million of BMS, followed by Merck with 350 million, 200 by Roche, and 150 by AstraZeneca into the development of clinical trials. So heavy investment of the pharmaceutical industry, and right now, if you see these companies, most of them have presented as well data at ASCO this year, as some of them in phase 3 clinical trials. Again, this year, this graph shows how busy the competitive nature of these drugs are right now. If you look at the outer circle, you have the tumors where most of these drugs are developed, whether it's melanoma, non-small cell lung cancer, renal cell, but also cancers where immunotherapy historically haven't played a major role, like colon cancer, gastric cancer, hepatocellular cancers. So you move further into the inner part of the circle, go from phase 1 clinical trials to phase 2 to phase 3, and the kind of drugs as monotherapy, Nivolumab, Pembroizumab, the Roche and PD-1 inhibitor, or AstraZeneca's MedImmune compound, they're all in this phase 3 circle right now. So it's a bit like a horse race, lots of monotherapy data, but also you can see followed very closely by combination therapies, and I will highlight some of those as well. So for me as an oncologist, really the immune therapy field started with first clinical data, major important data, were presented in 2010 at ASCO, so 5 years ago, when we talked about the CTLA-4 blockade and used a drug called Ipilimumab for the first time in patients with melanoma. This is kind of the setting the scene drug in a way that immunotherapies work, and I will just highlight a few things here. So the T cell is usually activated when antigen is represented by the antigen-presenting cell, and T cell receptor, which is here TCR, is docking onto the to the receptor at the antigen-presenting cell, and then the T cell gets activated and doing what it should do. It usually recognizes and distinguishes if it's self or if it's foreign, and if it's foreign, it starts to attack these foreign proteins. And CTLA-4, in a way, in this part is then inactivated. However, if T cells getting too active, CTLA-4 is actually then the receptor is expressed, and the B7 receptor is neutralizing the CTLA-4 signaling, so T cell is inactivated. And this often happens in cancer. CTLA-4 is expressed on T cells, and the receptor is inactivating, CTLA-4 receptor is inactivating the T cell function. And the drug, which is we call Ipilimumab, which is approved in melanoma, is the first drug actually which particularly blocks the CTLA-4 receptor. And by doing this, you could potentiate T cell function or reactivate T cell function, which then in turn could help recognizing foreign protein or cancer protein. And so, you know, in this summary, T cell, the Ipilimumab blocks the CTLA-4 receptor and potentiates T cell activation. The study I'm talking about is the study 24. It's a randomized phase 3 study, one-to-one randomization between standard chemotherapy in patients with metastatic melanoma. Standard chemotherapy for many, many years was dacarbazine given every 3 weeks for 8 cycles. And patients received plus minus either placebo or the Ipilimumab every 3 weeks for 4 doses. And then patients did well and could receive Ipilimumab for another every 12 weeks at 10 milligrams. And although the progression-free survival, as you can see here, didn't show any major difference in the median, only 0.2 months, which is equal to 1.5 weeks. The statistical value was highly significant, but more importantly, what we can see here is that the overall survival was improved by 2 months, and the hazard ratio of 0.72 means a risk reduction by patients who received Ipilimumab of 28%. So, and which resulted in median by 2 months survival benefit. What I really want to highlight here is that the progression-free survival was actually not different. The first tumor assessment was done after 2 months, and before these drugs, these immunotherapies actually started to work, and so I'm going back here, takes actually a while, and the net benefit of these immunotherapies actually is in the activation of the immune system, which we see here in the overall survival curve as a longer survival at the end of the curve. So the kind of increase from 10% long-term survival to 20% long-term survival, or at 1 year from 36 to 47, at 2 years 17 to 28, and third year from 12 to 20. That's really the long-term benefit of a reactivated immune system. So we wouldn't necessarily expect an early response or a significant difference in progression-free survival. But what we have seen here certainly is the overall survival benefit. In terms of response rate, as I said, there was not a major difference. But patients who responded, you can see down there in the line, patients who responded had nearly a 20-month response compared to patients of only 8 months once they responded. So I think that's very important as well. So responders who did respond very early had a long-term and maintained response. In terms of adding these immunotherapy, Ipilimumab, to the standard chemotherapy, as you can see, resulted in increased toxicity, grade 3, 4 toxicities, in around 50% of patients, although there were no treatment-related deaths. This toxicity needs further discussed and highlighted in a way, as I'm doing here right now. Most of these toxicities actually, in fact, were immune-related toxicities. Immune-related toxicities, when I'm talking about this, is that in a way with these immunotherapies, we are artificially overactivating our immune system, and we get side effects like skin rashes, diarrhea, colitis, reflected by an overactivation of the immune system, and which is different to the classical chemotherapy side effects where you just, with cytotoxics, kill fast-growing tissues with hair loss, low white blood cell counts, or mouth ulcers. And so completely different toxicity profile are very important for the community-based oncology to learn this, that we actually manage these side effects differently, often with immune modulating agents like steroids. And I will discuss this later on with you in more detail. These are the kind of skin changes we have seen. And so for Ipilimumab, the kind of setting the scene, first randomized phase 3 trial showing that immunotherapy in metastatic melanoma is superior to standard chemotherapy. Obviously, currently, several of trials are ongoing to test this compound in the adjuvant setting in different ways and different combinations. Ipilimumab as well was tested in non-small cell lung cancer in combination with chemotherapy. And here, a phase 2 study of 200 patients, where patients either received 6 cycles of standard chemotherapy, paclitaxel, carboplatin, or 2 different doses or schedules of dose administration of Ipilimumab, either concurrent or in a phased way where patients received either chemotherapy and then followed by Ipilimumab. Just what I want to highlight here as well, that we have in the phased arm compared to the control arm a better control, tumor control in terms of progression-free survival, but also response rate, and significantly prolonged survival and benefit of around 4 months. I need to be cautious here. This is a phase 2 study in only 200 patients. But what I want to highlight is by scheduling using different ways of just concurrent use of Ipilimumab and chemotherapy, the kind of phased arm seems to be have a better outcome. And if you look at the outcome for patients looking into the subtypes of lung cancer, non-squamous versus squamous, it seems to be that here the patients, if you look to the left side, these are the patients who are benefiting from Ipilimumab. The squamous cell histology seems to improve, have a better outcome than the non-squamous, the adeno histology. And so in summary of this phase 2 study, this is the only phase study in terms of randomized study in lung cancer where we actually see an overall survival benefit. The primary endpoint of immune response, progression-free survival was met. Risk reduction here in the hazard ratio was about 28%. The grade 3-4 toxicities are manageable, and further studies, this is what we also said, are awaited. So I'm changing now from CTLA-4 to probably the more exciting compounds or the drugs targeting the PD-1 receptor or PD-L1, the ligand. So if you see on the left-hand T cells, not only express CTLA-4 and other receptors, but also PD-1. PD-1, the program death receptor, which once the ligand binds to PD-1 and T cells get inactivated, and we know that tumor cells can actually express PD-L1 to a high rate and in a way neutralizes T cell function by the PD-1 receptor. So strategy here are to either target PD-1 directly, the receptor, or PD-L1, the ligand, so neutralizing the ligand. So 2 different strategies, and I want to share some of these with you. Here in the histopathology slide, we can see that some of the tumors heavily express PD-L1, which in a way works like a shield, like a radar shield for cancer cells, so that T lymphocytes who usually would or try to recognize cancer protein get neutralized. And there's certainly a big debate right now, and I will discuss this with you as well. Is this PD-1 expression on tumor cells or stroma microenvironment? So I will discuss this with you in more detail. But you can see across the board, whether it's non-small cell lung cancer, squamous or adenocolon, melanoma, renal, there's a good prevalence to call this an interesting target, potential biomarker, and a good strategy to test this drug in these tumors. And the first drug, the first data we were presented in the New England Journal in 2012 for phase 1 data of Nivolumab, a PD-1 inhibitor, in patients where we thought immune therapies might be more beneficial, melanoma, non-small cell lung cancer, and renal cell cancer. As you can see, the 1-year survival, 2-year survival, and the median overall survival are pretty impressive for phase 1 studies. So we actually, in this study, we didn't only see potential safety signals, but also efficacy signals and prolonged survival rates. Although these were not compared, this was not randomized, these were kind of phase 1 impressions. But on the right side, what you can see here, patients, especially with melanoma, were on treatment for more than 140 weeks and so on. In this phase 1 study, the CT scans, you can see very different patients with renal cell, melanoma, and lung cancer had responses in these images. And if you look at the, part of the Nivolumab phase 1 study as well, the progression-free survival, overall survival, and think about the tail of the curve, the 2-year survival, 3-year survival. We're talking about 20%, 30% at 2 years, patients with long-term benefit. And it seems to be as well, looking at the dose, the red line on the right here under B is 1 milligram, the yellow 10 milligram and 3 milligram. That's the dose which had the best results in terms of survival, overall survival, and that's the kind of dosage which was further investigated. And diagram C here as well shows the tumor shrinkage. Everything which is south of this dark black bold line means response, but also then the duration over time. So long-term responders, and if you look under D, these were lung cancer patients, and this really applies for both subgroups, the squamous and non-squamous histology. Really very encouraging data. And based on this and the randomized trial called Checkmate-017, where this drug was tested in the second-line setting. So patients had first-line treatment, standard first-line chemotherapy treatment, and patients progressed on this. These patients were randomized in a 1-to-1 session to either Nivolumab, the schedule at 3 milligrams every 3 weeks, or the standard of care treatment, docetaxel. And this was the subpopulation of squamous cell non-small cell lung cancer. And you clearly could see here that the patients who received Nivolumab had an increased survival benefit, highly significant compared to docetaxel. Based on these results, this drug was actually got fast-track approval in the United States. So positive randomized phase 3 study, Checkmate-017. And this year's ASCO, the Checkmate-057 was presented. Interesting, same drug, same study design, same setting in second-line setting, but the patients were non-squamous cell lung cancer. So here the same actually could be shown. Patients with adenocarcinomas, non-small cell lung cancer, in this setting had a significantly improved median overall survival of 12.2 months versus 9.4 months. And patients who responded as well had a significantly longer duration of response of nearly 18 months versus 6 months. Again, very interesting data, but important. This is in line with the early signals we have seen in phase 1. So for Checkmate-017 and 57, in both studies, it clearly improved survival in both squamous and non-squamous cell histopathology, non-small cell lung cancer. It is interesting, some of the data, the Checkmate-067, Checkmate-067 presented was that actually patients with the, and I discussed it before, the PD-L1 expression on the tumor cells seemed to be an interesting marker, potential biomarker. So the more PD-L1 expression you had, the better patients did. And in terms of side effects, these are consistent with the ones we have seen early in the phase 1 studies and often are inline immune-related skin rash, diarrhea, colitis, or pneumonitis, or hepatitis as well. So Nivolumab, the PD-1 inhibitor, has been tested now in various different tumor types in phase 1 and in solid tumors, but also non-solid tumors like Hodgkin's lymphoma. Based on these results, I mentioned before, Nivolumab has been received FDA approval for metastatic squamous cell lung cancer after first-line treatment, also a breakthrough therapy designation for Hodgkin's lymphoma, and is approved for metastatic melanoma. And I'm just, because I'm talking of a drug class, Pembroizumab, Merck MSD, PD-1 inhibitor as well, tested in many in Keynote-001, the phase 1 study, but also subgroups in this study and further Keynote studies has been tested in various different cancers. Positively, same story here, a variety of tumor seems to respond. Several presentations at ASCO want to highlight in HCC, in liver cancer, primary liver cancer, and also in patients who had microsatellite unstable colon cancer, very interesting data which need to be further investigated. But as well, Pembrolizumab has been FDA approved for melanoma in BRAF positive V600 and negative melanoma patients who progressed on Ipilimumab, and also received breakthrough designation in non-small cell lung cancer, EGFR and ALK negative lung cancer in the second-line setting, so similar to Nivolumab. The Roche compound here has been tested in bladder cancer. Again, everything highlighted here in green, which is the 30% mark. It's a very light black line. Everything south of this is response, and you can see the days on studies looking to the right are prolonged responses. Again, in a disease, bladder cancer, second line or more than 3 lines of therapy, patients had prolonged responses. Based on this, again, this compound received breakthrough therapy in bladder cancer, but also in lung cancer after platinum-based first-line therapy. Other data here are the AstraZeneca's compound, again, has been presented in various different tumor types. Same story here. Lots of patients, subgroups, and cancers are responding for a long time. So the question right now is we have various drugs approved, PD-1 and PD-L1 inhibitors. We have the first drug, Ipilimumab, successfully. So the question is, can we actually combine immunotherapy? Can we add a PD-1 inhibitor to Ipilimumab, for example? And so the hypothesis is obviously lifting these long-term survival curves at the end to benefit patients long-term. And obviously this has been done, and so Nivolumab has been combined with Ipilimumab, and if you look at these curves, the left, the waterfall plot, you can see several patients with dark, south-facing marked columns are responsive, several complete responses in patients with melanoma, quite significantly responding, and also we see interestingly early responses. So I mentioned before with the CTLA-4 inhibitors, we haven't seen so many responses very early on, but you can see here patients responding at week 10 in the majority of cases, and patients have long-term benefits. If you look at the summary, Ipilimumab alone or Nivolumab alone, or the combination Nivolumab in the range of 7%, Ipilimumab less than 10%, Nivolumab less than 30%, but the combination nearly 50% of overall response rate, and quite dramatic responses in more than 80% tumor reduction. These are very early on responses. We have seen, obviously, we need to buy this in with more toxicity, autoimmune-related toxicities, again, skin rash, pruritus, hepatitis, one of the main challenges, an increase in the liver function test, and colitis, represented as diarrhea. These kind of toxicities, as I said, are in a way of concern and need to be treated different to the standard chemotherapy, and often with immune modulating agents. And here, very recently, earlier this year, published presentation, a case report of patients with melanoma, big bulky melanoma under the left breast of a patient, which after one dose of the dual immunotherapy, Nivolumab and Ipilimumab, resulted in a massive response. You can see the photos, but also the CT scan, which is pretty impressive. Not only have you nearly a hole in the chest wall, but also several liver lesions are kind of zapped away by this combination. So very dramatic responses early on in this case report. The first data has been as well presented as part of phase 2, consistent with phase 1 data. You have several patients having, if you look under A, complete responses, but the majority patients, really 70% of the patients have everything looking south, here facing south, are partial responses. 70% of these patients quite impressive in this randomized trial. Whereas if you look at the right side there, the patients who only received Ipilimumab, the response rate are in the range of only 5%. And looking under C, the progression-free survival curve of the combination, although the numbers are only 70 patients versus 40 patients, and you can see the curve separating nicely very early on. And the hazard ratio of 0.4 means actually a 60% risk reduction of progressing with the combination. Again, this slide is very busy, but it will highlight, and you will get these slides as well to look in more detail. Most of the patients, actually all of the patients, were treated with Immunomodulatory medication, which is steroids, often to start with oral steroids, and higher toxicity cases, intravenous steroids, or even in very severe cases where patients had colitis and severe diarrhea, patients need to be admitted and received drugs like Infliximab and drugs which are often used in autoimmune diseases. So a completely new spectrum how to manage these severe toxicities. Certainly, as seen in the phase 1 study, this phase 2 study resulted in increased autoimmune toxicity. Checkmate-067 is again presented this year, the first randomized study of Ipilimumab plus minus Nivolumab against Ipilimumab alone. So 900 patients were randomized 1:1:1, patients with unresectable stage 3 or 4 melanoma. You can see patients who here in the middle and I mean these patients received Nivolumab and Ipilimumab. If you look under the curve under the dotted line there, facing southwards, significant proportion of patients responded compared to the green and compared to the blue, where patients only received Nivolumab or Ipilimumab. So a combination in terms of response significantly better. In terms of progression-free survival, which was the endpoint, and the overall survival hasn't been presented at this meeting. Interestingly, you see that certainly Ipilimumab was inferior to Nivolumab or Nivolumab plus Ipilimumab. So there was actually, however, no separation between Nivolumab and Ipilimumab, which is interesting. If you're looking, and I mentioned this before, the PD-L1 expression seems to be an interesting biomarker However, if you look at the patients who had PD-L1 expression, there was actually no differentiation between Nivolumab or Nivolumab plus Ipilimumab, although both were certainly better than Ipilimumab alone. In patients who didn't have any PD-L1 expression, interestingly, the Nivolumab and Ipilimumab combination was superior to Nivolumab alone. So I think we need to wait for more data, and certainly the biomarker PD-L1 expression is not so clear here in this setting compared to, for example, in lung cancer. So Checkmate-067, again, the first randomized phase 3 study showed an increased progression-free survival of 11.5 months of the combination Nivolumab plus Ipilimumab versus Nivolumab alone, 7 months, and versus 2.9 months for Nivolumab. Also, with the combination, the grade 3 and 4 toxicity rate increased to nearly 50%. And actually, in fact, nearly 30% of patients had to stop due to toxicities of this combination. Important to mention that there were no treatment-related deaths. So it's really important to highlight there increased toxicities which we see with the combination. So the other question, obviously, as well, I've shown you nice data now. If you look at the green line and the red line, we increasing the tail from the 10-20% to the 30-40% long-term survival. Is how can we combine these drugs with our targeted drugs, especially I'm talking about melanoma, the BRAF V600E or K melanoma, so where you usually see an improvement in progression-free survival and improvement in response rate, so shifting the line, the survival, progression-free survival curve from left to right. So how can we combine this? And again, first data have been presented at ASCO phase 1 data, so very early data. And there's a good rationale, obviously. And we know with BRAF MEK inhibitors, the median progression-free survival is around 11 months, and then patients tend to progress and are not responsive anymore. So with the hypothesis that immune therapy is more durable, and combining this, that makes certainly sense. And we have had very early data in 2011 when the first combination of Vemurafenib, the BRAF inhibitor, plus CTLA-4 Ipilimumab was combined. This was a report in a New England Journal of increased toxicities, especially liver toxicity. So this was not brought forward in this combination. So the kind of double targeted therapy of BRAF MEK inhibitor plus PD-L1 inhibitor was really exciting to see. And I only want to focus on the first one because the first one here of the randomized phase 1 study was patients with BRAF mutant melanoma who were then treated with trametinib, the MEK inhibitor, dabrafenib, the BRAF inhibitor, and then the PD-L1 inhibitor. The other two arms were patients who were wild type, melanoma wild type, and there's certain hypothesis around even if you treat wild type melanoma patients, give targeted drug like MEK inhibitor, and then treat with an immune stimulating drug, the immune responses are much better. But I don't want to focus on this. It's really what I want to show you, the triple combination here, only in 26 patients, with 70% of patients had response. All patients had disease control rate, and significant number of patients had prolonged disease stabilization, and patients, nearly 90% had ongoing long-term response. So this study really, for the first time, shows that it's feasible to combine targeted drugs and immunotherapy in very selected patients. Certainly, we need to be cautious here. This is a phase 1 study, but I think that's where we are moving to show the hypothesis in phase 2 and then later stage trials. We talked about trial results, exciting trial results, but we also need to be aware that there are severe challenges around this, and I highlighted a few of them. One obviously is can we use for these often very expensive drugs and predictive marker? Can we identify patients who do better than others? Can we identify patients who become resistant to immunotherapy? And how do we manage actually side effects with these drugs appropriately, and not only in specialist drug development centers, but in the community, in the district general hospitals where these patients often are. We see challenges in a way around immune response, the way we historically look at response via RECIST criteria and may not always apply to patients who are undergoing immune therapies. Combinations are highlighted a bit, and at what line of therapies are we using? Are we using these drugs in the adjuvant setting as maintenance therapy, or really late end stage when patients fail standard therapies? And obviously, I will highlight as well the cost issue as well. So coming back to the identifying patients who are responding, I think the biggest challenge right now is that several companies develop as well, in conjunction with their drug, biomarker assays, and the challenge we have, these assays are often not fully validated. They have variable cutoff levels for positivity, and that's one of the challenges. What is PD-L1 positive with the Merck compounds or the bioassay? What is PD-L1 positivity with the Roche compound, for example? So there are differences in terms of cutoff and test, and I think that's one of the challenges we currently facing. And then you can see, however, that actually, if you look at the kind of the PD-1 Nivolumab, Pembroizumab, the PD-1 inhibitors, and then the MedImmune, AstraZeneca compound, Roche compounds, these lines here show that it looks like that patients with PD-L1 expression do better than patients who don't have PD-L1 expression on their tumor. The problem is, however, that you can see that patients, in a still significant number who are PD-L1 negative on their tumor, are responding as well. So how are we dealing with this challenge? That actually a patient who's negative is, we exclude them from clinical trials or from the treatment of immunotherapy. So I think that's something we need to work out, and it applies across the various different drug development programs of the companies, these challenges. And then, obviously, as well, how often is actually PD-L1 expressed? And right now, we're using immunohistochemistry as a test. And I recently quoted, and you in the arena of drug development may remember, HER2 expression in gastric cancer was a very similar challenge compared to breast cancer. HER2, for example, in breast cancer is homogeneously expressed, whereas in gastric cancer it's very heterogeneously expressed. And this may also apply to PD-L1 expression on tumor cells. And then also we know that the prognostic significance is, we don't know actually whether PD-L1 is a prognostic factor. But I think that is of importance to highlight. I highlighted also earlier that PD-L1 expression of tumor cells versus stroma cells might be completely different. Also T cells express PD-1 receptor, and to really highlight the response in this setting is difficult to say. There are other factors which may play a role, which are interesting. We know tumor-infiltrating lymphocytes are in some cancers correlating with improved clinical outcomes. So, which means the more T lymphocyte infiltration in your tumor, the better your outcome is. The question is this relevant to PD-L1 inhibitors? We don't know, but this could be an interesting cofactor which we need to look into. And then also, we know this is a very interesting paper presented that patients or tumors with a very high burden of genetic alteration seem to do better. This is probably explained by the fact that they express more tumor antigen, and PD-L1 inhibitors may work better in these cancers. So high oncogene or alterations in genes may also predict for a better outcome. But again, these are hypothesis-generating papers, and we need to apply these in real-term in clinical trials. But I just want to highlight here that the jury is not out yet. In terms of imaging, I mentioned this, we are not using for immune therapies anymore the classical RECIST criteria. Although we're using them, we need to be aware that new immune response RECIST criteria have been identified. It is actually, in fact, if you look here at these lung cancer picture, patients on the left pre-treated, then 2 months on treatment with immunotherapies, you see the tumors looking larger, and this patient would have come off due to progression of disease under RECIST criteria. But we know that this actually, what we call pseudo-progression, could be related to the fact that actually T cells are infiltrating the tumor. We actually have T cell infiltration causing this pseudo-progression. And then 4 months later or 2 months later, you can actually see the tumor is really gone. And this phenomenon is occurring in around 7 to 10% of patients. So that's why we're using beyond RECIST criteria, the classical response criteria, immune RECIST criteria. I highlighted how do we manage adverse events. Compared to chemotherapy, obviously, these drugs are not the classic, don't have the same profile, not nausea, vomiting, diarrhea, neutropenia, hair loss, and the like. We're dealing here with immune-related adverse events, and that's really important for the community-based oncologists, and especially, district general hospital. You have patients with 10 times diarrhea per night. You just don't put them on loperamide and replacement fluids. You actually need to treat these patients with steroids, often intravenous steroids. And shortness of breath of patient on lung cancer on immunotherapy often can be related to pneumonitis. Again, needs to be acutely treated with intravenous steroids. So completely different spectrum, and teams need to be aware about it. From our clinical experience, it looks like the PD-1, PD-L1 inhibitor are less likely to cause these severe autoimmune reactions compared to CTLA-4. I think that's interesting clinical observation, and obviously important for the combination studies we discussed. And here I just wanted to highlight the kind of spectrum of side effects we've seen. Not only the kind of hepatitis, pneumonitis, and skin rash, but also often endocrine dysfunction, so thyroiditis, the changes in your thyroid function have been observed. So treating a patient on immunotherapy, you need to really think like a rheumatologist, and that's the way we do and enlarge our knowledge how we treat these patients and how to overcome these overshooting immune responses. In terms of the kinetics, when do they actually appear, these side effects? It seems to be rashes, probably the earlier sign of side effects. But then 6 to 8 weeks down the line, patients may develop liver toxicity. I mentioned the endocrine dysfunction, hepatitis as well, happens down the line, 6 to 8 weeks. So again, teams need to be aware. It's not the classical chemotherapy side effects 7 to 10 days after initiating of chemotherapy. These side effects often happen down the line, start very subtle, and that's kind of important to have clinical follow-ups scheduled around the kind of kinetics when these immunotherapy start to kick in, the side effects start to kick in. Okay, cost, certainly you can see here, this is self-explanatory in melanoma, the kind of increase of cost, the BRAF-MEK combination in light blue, a slow increase over the next 5 years, but really it's the immune checkpoint inhibitors attributing significantly to cost. And one of our colleagues, Dr. Salz from Northern Kettering at ASCO, commented on the Checkmate-067 study, and he compared it very practical, the cost of 1 milligram Nivolumab and 1 milligram Ipilimumab against the cost of 1 milligram of gold. And these costs are about 4,000 times higher. So I don't want to comment on this, but these are the kind of reality implications of cost in this arena. So I think we need to be very clear that we need to define the right patients for who most likely benefit. And we certainly have lots of work to do on the biomarker development. We need to define as well what tumor types do best out of it, and need to put this into the context of costing. So where from here, I want to finish here. I think the PD-1, PD-L1 inhibitor story is kind of, it's pretty equivalent in terms of outcomes. I think there's fine-tuning around schedule, duration of therapy. We don't know if an ongoing treatment until disease progression for immunotherapy is important, or just 3 or 4 months treatment of immunotherapy enough to get the immune response. Do we use therapy sequential? Are we using them as maintenance therapy, especially in the adjuvant setting? These trials are currently all ongoing. The PD-1 expression, I think, is one of the markers of interest, but I think there will be, based on as well the definition of PD-1 expression, whether it's tumor, stroma cell, microenvironment, T cells, or like, there will be more data coming up. But I think generally PD-1 expression is certainly helpful. The combination of therapies are important, and we haven't looked really into when patients, and we have seen not all patients actually responded to these immune therapies. Why are they not responding? So what are the mechanisms of primary resistance and also resistance while patients progress? And again, clearly reimbursement strategies. So really overall, very exciting times and lots of, very stimulating discussions at ASCO, I think, for everyone involved, whether it's a clinician, whether in pharma biotech, and obviously patients. You can imagine after this ASCO, there were hundreds of patients bombarding our websites and wanting to have access for these drugs. So challenging times for us, and I want to finish here and open for discussion.
So thank you very much, Dr. Arkenau, for an excellent presentation. I just invite now the callers that are on the conference line to come off of mute and ask any questions that you may have. Just while we're waiting for people to come off mute, Dr. Arkenau, I had one question, which is around what was the data that was presented here, but around solid tumours. Is there any evidence for this class of therapy working in hematological malignancies?
Yeah, absolutely. I mean, you have seen actually the Pembro and Nivolumab, the PD-1 inhibitors were very small phase 1 studies. Phase 1-2 studies showed activity in Hodgkin's lymphoma, so very exciting data. And I think it's a question of time when these move into the non-solid tumor arena, so hematology, absolutely, probably in combination with newer drugs like BTK inhibitors, PIK inhibitors, and PI3 kinase delta inhibitors.
Okay, thank you. Are there any questions on the line? Okay, then, well, I'd like to thank Dr. Arkenau for today's excellent presentation. We will be following up with all of you over the next coming days with access to the slides and the recording for any of you that may want them. And we look forward to seeing you at our next event. Thank you very much. Goodbye.
Thank you.